Thank you for joining us today on Health HIV's Telehealth Summit on implementing telehealth during COVID-19. We appreciate you being with us virtually today. And again, just a reminder, please mute your audio for the duration of this session. My name is Marissa Tonelli. I'm Health HIV's Director of Health Systems Capacity Building. And I will be hosting our virtual summit today, along with a number of my colleagues who will be moderating some of the breakouts. Just in a few words of introduction, I wanted to mention the historic day yesterday, which was historic for many reasons, including marking the 1 year since the US confirmed its first case of COVID-19. And since then, there have been 25 million cases and over 400,000 deaths. We also know that many researchers have reported a variety of challenges with HIV, STI, and viral hepatitis services during that time, as a result of disruptions in service, specifically to the diversion of the health systems, capacity, so staff being reassigned, resources being reallocated to pandemic response, in some cases a lack of or limited access to health facilities during lockdown and quarantine, as well as other quarantine and social distancing orders and fears of getting sick. And researchers are also reporting that some of the services, essential services that may help prevent and improve health outcomes for people living with or at risk for HIV, viral hepatitis, and STIs has been decreased during this time, or certainly is functioning at a significantly reduced capacity. So the reason we wanted to come together today is because we know that telehealth is really a great opportunity to continue these essential services. Today in this 2-hour summit, we'd like to provide information on the state of telehealth, and bring together experts to highlight what is happening in the field and share resources, lessons learned during this COVID-19 pandemic and before. We will break out into concurrent sessions, and so you will have the opportunity to share more and connect more with other colleagues and experts in the field. Again, recording this session, so please mute your audio. There's multiple ways to mute your audio and your video. Just make sure there's a red X through your microphone and your camera. We will be having some opportunities for interactivity. Since this session is a larger session, we'd like everyone to utilize the chat box. You can chat with everyone, you can chat with the co-hosts, and if you have a specific question that you would like to chat privately, please do so to myself, Marissa Tonelli, or Eve Kelly during this session. You also can privately chat the presenters today, who I'll introduce in just a minute, if you would like some more specific information about their programs and what they shared. I also wanted to point out that we do have a telehealth HIV program at Health HIV, which is why we're hosting this session, really to make everyone aware of the services and the resources that are available and the educational opportunities through Telehealth HIV, which launched last year in March. And so if you're interested in more information specific to telehealth and HIV, you can visit www.healthhiv.org/telehealthhiv for more resources, archived webinars, and continued access to our listserv. And so you can sign up for more opportunities like this. Our team today, myself, I'm joined by Andrew Pollack, the Senior Manager of Capacity Building at Health HIV, who will be moderating our session on telehealth and technology. Eve Kelly, who will be moderating the teleprep session. She's our capacity building coordinator, as well as Grace Hazlett, who is our intern in capacity building, who will be moderating our session on provider readiness for telehealth. Our agenda today, we are starting now at the state of telehealth, and our breakout sessions will start at 3 p.m. Eastern. We did ask people to pre-select their breakout sessions in the registration link, but you will have the opportunity to select which session you would like to go to. So we'll show you how to do that once we transition to our breakouts. And then we'll close this summit at 4 p.m. So I just wanted to share that with you as an agenda. So today in this general session, we will be going over how telehealth is currently being utilized, some strategies right now, and some of the data that we're seeing around utilization during the COVID-19 pandemic. We have speakers to talk about changes in reimbursement policies and structures for telehealth, specifically in Medicaid. And then we'll also be introducing an individual from a large university who can talk specifically about how they implemented telemedicine to improve HIV health outcomes among minority people living with HIV in an urban area. So again, I'm really excited to have our speakers here today. I'm joined first and foremost by Dr. Circe Lecomte, and Circe Lecomte serves as Health HIV's Director of Health Services Research and Evaluation at Health HIV. She received both her Master's of Science and her Doctor's of Science from the Harvard University School of Public Health in the field of social and behavioral sciences, and her research uses both qualitative and quantitative methods to develop and evaluate cutting-edge interventions to promote sexual health among vulnerable LGBT youth of color. I'm also joined by Emily Yoder. Emily is an analyst in the Division of Practitioner Services in the CMS Center for Medicare. She has worked on Medicare physician fee schedule, rate setting, and policy development since 2015 on topics such as primary care evaluation and management visits, communication technology-based services, and Medicare telehealth. Dr. Ritu Graywal is an associate professor in the Department of Community Health and Family Medicine at the University of Florida College of Medicine, Jacksonville. She is the clerkship director for the third year family medicine clerkship, a fellow of the American Academy of Family Physicians, and has received the AAFP Award for Excellence in Graduate Medical Education and the Arnold P. Gold Foundation Humanism and Excellence in Teaching Award. She enjoys focusing on wellness, telemedicine, office procedures, and teaching medical students. So I hope you'll join me in engaging with our presenters today. We have a great panel set up for you. So I'm going to go ahead and turn it over to my colleague, Dr. Circe Lecomte. And again, just want to remind everyone, please, to mute your lines while Dr. Lecomte is speaking so we can reduce any background noise. Thank you so much.
Thank you, Marissa, for that very kind introduction. And welcome everyone to welcome to today's telehealth webinar, Telehealth and COVID-19 Implications for HIV Care Delivery. We're so glad to have you joining us today to discuss this important and fast-changing topic to improve care access for people with HIV during the COVID-19 pandemic. Telehealth holds so much promise in ensuring greater access to care during this time, and it is certainly here to stay. But the question is, are medically underserved populations able to access the full benefits of telehealth? Next slide, please. Defined by the Centers for Disease Control and Prevention as two-way telecommunication technologies to provide clinical health care through a variety of remote mechanisms, telehealth growth was undergoing a determined upswing even prior to the pandemic. According to the American Hospital Association, the percentage of hospitals fully or partially implementing computerized telehealth increased from 35% in 2010 to over 76% in 2017, with many state Medicaid program providers and private payers offering some coverage of telehealth services. Less than 3 years later, adoption of telehealth is almost universal across the healthcare arena in one form or another, and its technology is becoming more sophisticated, user-friendly, and secure all the time. The CDC study Trends in the use of telehealth during the emergence of the COVID-19 pandemic, United States, January through March 2020, published this fall in Morbidity and Mortality Weekly Report, captured this trend through a comparison of telehealth use from January to March in 2019 to January to March 2020. A graph from this report, which appears on the right side of this slide, compares telehealth uptake during the first quarter between 2019 and 2020. You can see that telehealth visits in the first quarter of 2019 were flat and actually seemed to decrease slightly prior to the second quarter. 1 year later, that changed. During the first quarter of 2020, the number of telehealth visits increased 50% compared with the same period in 2019. Uptake was flat until week 9, when initial COVID-19 protocols were implemented nationwide and resulting in closures of clinical offices. There was a 154% increase in telehealth visits noted in surveillance week 13 in 2020 compared with the same period in 2019. The reasons for these visits also changed, with most appointments, of course, prior to March 2020 occurring for reasons other than COVID-19. As more healthcare sites closed or new protocols were in place to deal with the possibility of infectious patients, the portion of COVID-19 related encounters conducted through telehealth significantly increased. By the end of the final quarter of 2020, there were an estimated 1 million telehealth visits conducted in the US. The American Medical Association estimates that physicians and other health professionals are now seeing 50 to 175 times the number of patients via telehealth than they did before the pandemic, with 46% of patients now using telehealth to replace canceled in-person visits, up from just 11% of all patients who used telehealth in 2019. A study of HRSA-funded health centers found that 45% of all HRSA-funded health centers, more than 30% were doing telehealth visits in July 2020. The other one half were using less than 30%. Next slide, please. As the use of telehealth has grown, so has its perceived acceptability among providers and patients alike. Among physicians, we've seen that 64% reported a greater comfort with telehealth than before COVID-19, and 74% were reporting a high satisfaction with telehealth overall. Customers have reported similar high levels of acceptance, primarily through just becoming more accustomed to it as time has gone on since March 2020. Over 3/4 were highly or moderately likely to use telehealth services in the future, and just under 3/4 reported high levels of satisfaction with telehealth. Indeed, the volume of internet service searches for telehealth related topics has grown dramatically since March 2020. Searches for terms like telehealth doctor have grown 928%, and the phrase telehealth and telemedicine near me has grown 3,500%. Most of these searches are conducted across 50-50 between computer and mobile devices. Next slide, please. While telehealth has become more acceptable, its accessibility still remains a matter of conjecture. COVID-19 has required us to create former in-person engagements in an online environment. While much of that has been done successfully through mechanisms like telehealth, rapid adoption of these technologies has shed light on ongoing disparities in internet and mobile connectivity and equipment access. Indeed, the National Cancer Institute's Health Information National Trends Survey has described communities that fall short on the resource poor side of the digital divide as living in a veritable information desert. Persons in rural areas and older persons were heavily impacted. Indeed, prior to COVID-19, the Harvard T.H. Chan School of Public Health noted that over 1/5 of persons living in rural parts of the United States reported limited or no access to high-speed internet connectivity for themselves or their families. And a study conducted this past year by the Pew Research Center reported that over 1/4 of US adults over the age of 65 said they did not use the internet. Populations disparately impacted by diseases like HIV, HCV, STIs, and now COVID-19, including underserved populations like LGBT persons of color, or those engaged in substance use, are more likely to experience varying levels of computer literacy and access to mobile and internet connectivity due to a variety of reasons, such as unstable housing and loss of mobile phones and connectivity. It is not surprising that the first large-scale study to unravel the inequitable access to telemedical care, published this past month in JAMA, found that persons who are racial and ethnic minorities, are 75 or older, are non-English speakers, or are accessing Medicaid coverage have completed fewer telemedicine visits on average. Next slide, please. Health HIV has been working to understand inequities in telehealth access through the agency's Health Services Research and Evaluation Division. This division advances effective prevention care and treatment for people with and are at risk for HIV, HCV, STIs, and COVID-19 through the use of novel approaches to study design and data analysis. The results from these efforts guide and enhance agency programming across our education, capacity building, and advocacy programs in order to ensure quality improvement and help disseminate findings. One of our pivotal research initiatives is the National State of Surveys, which you may have seen on our website and in other capacities. These surveys leverage validated measures and other adapted scales to understand the current landscapes of the healthcare arena and how they're impacting specific groups of clinical and behavioral providers and our customers. These research initiatives include the state of HIV primary care, the state of HCV care, the state of aging with HIV, the state of ASOs and CBOs, and the state of LGBTQ health. In addition, we now have the state of telehealth and HIV prevention care and treatment. Next slide, please. Thank you. Health HIV's state of telehealth and HIV prevention care and treatment sought to identify models, methods, and practices and delivery mechanisms that providers were leveraging around telehealth and or telemedicine for HIV prevention care and treatment services during the pandemic. Conducted in July 2020, 256 respondents from AIDS service organizations, community-based organizations, and health centers responded to questions regarding their organization's approach to telehealth service delivery, barriers to telehealth implementation, and services offered via telehealth. Among the respondents, we found that just under 1/2, or 48%, had started providing telehealth services primarily because of the COVID-19 pandemic. 81% of all the respondents were delivering HIV services via telehealth. 71% interestingly said they would be very likely to continue offering telehealth after the pandemic was over or under control. Respondents, however, noted some barriers to uptake and utilization of telehealth. 58% of respondents said they were concerned with patient inexperience responding to health questions via smart devices without in-person coaching or a care provider. Over 1/2 were concerned that telehealth would be daunting to patients who were unaccustomed to smart devices. Interestingly, 1/3 of providers said that their patients distrusted the use of technology and access and care. And another 1/4 were concerned that patients' limited access to technology or wireless connection would keep them from engaging in telehealth overall. Next slide, please. Respondents noted that 60% or more were providing HIV clinical care, medical case management, and mental health services online. And another 46% said they were providing PrEP services. However, other key and pivotal HIV services had not been translated to the telehealth arena with such ease. Indeed, only about 19% of respondents reported offering medication-assisted treatment of opioid use disorder through telehealth, and just under 22% reported providing HIV testing-related services through a telehealth lens. Only 22.5% reported providing access to PrEP through telehealth. These are just a few examples of the inadequacies that have been highlighted around the delivery of services via telehealth via our survey. With the COVID pandemic continuing on, many people understandably do not feel comfortable going to their doctor in person. However, if an individual does not feel safe going into their doctor's office or does not have the technology accessible to them to participate in telehealth, they may go without care. Other areas of delivery that need to be considered as moving forward with COVID-19 and the continued uptake of telehealth includes health education and risk reduction, HIV clinical care and primary care, specialty care, outpatient ambulatory health services in particular, medical case management, namely treatment adherence, case management, including psychosocial and non-medical services, and mental health services. Next slide, please. The survey also revealed a number of reported patient barriers that came to light. When asked what challenges they've encountered with telehealth, providers noted that their patients identified several different shortcomings. 70% said that their patients did not have access to technology. Another 53% said their patients did not have access to a telehealth platform. Over 1/3 said they did not have internet access. And 34% of providers said patient education when it comes to telehealth was key in order to ensure its success. 27% said that their patients were reporting privacy concerns, while 26% said that there was just an overall need for additional funding to purchase technologies to ensure the success of telehealth in their practices. Next, please. Thank you. As I said before, telehealth is definitely here to stay. And as I noted previously in that recitation of statistics, over 70% of all persons who responded to our survey said that they would be delivering telehealth in the future. One of the respondents noted that we're now Alex Agsar, Secretary of the Department of Health and Human Services, noted that we're now aggressively looking at how to make the telehealth revolution a permanent part of American medicine. However, realizing that path forward cannot take place unless there's equitable access to telehealth among all of our underserved medical populations. Well, thank you again for joining us today, and I'm going to turn it back over to our next speaker. And if you have any questions, please feel to reach out to me, and good day.
Thank you so much, Dr. Lecomte, for going through some of that research data with us. I just wanted to take a brief break before our colleague from CMS joins to present, to share with you some of the data around where you, as participants and registrants for this summit, are today with your telehealth program operations. And I think this would be interesting to share. So about 1/4, 23%, had an operating telehealth program prior to 2020, but the majority, about 47%, nearly half, started a new telehealth program in 2020. And then about a third either plan to or are interested in telehealth services. So, the majority of organizations and respondents to this pre-survey in the registration are working in telehealth already have a telehealth program, but many are new as of last year. And so, we wanted to ask what your biggest barriers are. And I think it was interesting to look at, the anticipated barriers for those organizations and individuals who have not yet started a telehealth program. That was organizations' technology, accessibility of services for clients, and the cost are your biggest concerns. And then on the flip side, those who already have a telehealth program and started it last year, the biggest barriers for expansion and implementation are really mostly related to your clients. So making sure your clients have access, making sure that they are engaged in the telehealth services. So we'll get more into this, but I just wanted to point that information out because I do think it's interesting to see where we're at now and who's on this virtual summit today. So I'm going to go ahead and turn it over to our first speaker. Again, very excited to have Emily Yoder join us from CMS. So Emily, I will let you go ahead and get started.
Thank you so much. Hi, everyone. I am so happy to be with you today. So today I will be discussing how Medicare recognizes and pays for services that are furnished using communication technology, which includes Medicare telehealth, and how this has changed in response to the pandemic and the direction Medicare is taking telehealth outside of the pandemic, as described in the calendar year 2021 Physician Fee Schedule Final Rule. Next slide, please. And next slide. So telehealth services are reimbursed off the physician fee schedule, which is a $90 billion payment system. The payments must be resource-based. And when we're setting these payment rates, we take into account the physician work, or physician or other practitioner, I should say, since it's not just physicians, practice expense, which is things like clinical staff, office supplies, equipment, things like that, and also malpractice insurance as part of setting those payment rates. The payment is made at the level of a CPT or HCPCS code, with each code generally describing a discrete service. Next slide. Thank you. So Medicare uses the term telehealth in a very specific way. When we say Medicare telehealth, we are referring to services that would otherwise occur in person, but instead are furnished using communication technology. So the circumstances under which Medicare will pay for these services is outlined in Section 1834M of the Social Security Act. And I'll get into how we pay for other remote services in a bit, but I wanted to spend some more time diving into this very specific way that Medicare thinks about telehealth. Next slide, please. So the conditions under which Medicare makes payment for these services are specific and are outlined, as I said, in the statute. So the beneficiary must be in a rural area, and generally they have to be in a medical facility, so they can't be in their own home. There are a few exceptions. Congress has several times amended 1834M to remove geographic and site of service restrictions for beneficiaries with ESRD, for diagnosis and treatment of an acute stroke, for beneficiaries with a substance use disorder and co-occurring mental health disorder, and recently via the Consolidated Appropriations Act, which passed very recently, mental health services can also be now provided to beneficiaries regardless of geographic location or setting of care. The statute also limits the range of practitioners who may bill for telehealth. There's actually a list of practitioners that is enumerated in the statute. Most significantly, the statute excludes therapists. And by therapists, I mean physical therapists, occupational therapists, and speech language pathologists. They are not in that list of eligible practitioners in the statute. The statute also specifies that telehealth must be furnished using telecommunications technology. And our CMS's longstanding interpretation of this is live two-way audio video. There is an exception for this for asynchronous or store and forward communication technology, but those are only limited to federal telemedicine demonstration projects in Alaska and Hawaii. Next slide. Actually, if you go back one slide. Thank you. With few exceptions, Medicare telehealth services are described by existing CPT codes, and they're not valued specifically as remote services. And this is important because, as I said, the physician fee schedule's payment rates are generally resource-based. And in general, services that are furnished remotely have less sort of resource costs associated with them than services that are furnished in sort of a standard or more an in-person model. But Medicare telehealth is an exception to this. So a list of all the codes that we pay for as part of the telehealth benefit is available on the CMS website. And every year we consider public requests and also conduct internal reviews to determine if there are other services that should be on the Medicare telehealth list. We update the telehealth list on an annual basis, as I said, through the physician fee schedule notice and comment rulemaking process. And over the years, we've added a number of services to the telehealth list, including codes that describe a range of behavioral health and counseling services, as well as commonly furnished visits in the office, nursing facility, or inpatient setting. So when all of the conditions that I just described are met, Medicare telehealth, they reimburse as though the service actually occurred in person. Next slide, please. So moving beyond Medicare telehealth, CMS has a long-standing policy of paying separately for services that are furnished using communication technology that, as part of the provision of the service, but that we do not consider to be subject to all of those restrictions in 1834M. So for example, we've long paid for remote interpretation of diagnostic tests, care management services, and even the global surgical packages could be provided using some kind of, or a portion of them, I should say, could be provided using some kind of communication technology. That said, there was little in the way of discrete coding to recognize these services prior to the calendar year 2019 physician fee schedule, when we began paying for what we refer to as communication technology-based services. So because Medicare telehealth is really services that would be ordinarily furnished in person, communication technology-based services are defined as not being furnished in person or inherently non-face-to-face, or in some instances preventing an in-person service. So for example, we began paying for something we call the virtual check-in, which is a short service furnished with synchronous communication technology to assess whether a person needs to come in for an office visit. So if an in-person visit results, then the virtual check-in is bundled. But if there is no in-person visit, then the practitioner can bill separately for that virtual check-in, for that service where they interact with the patient to determine if the patient actually needs to come in to see them in person. We also pay for interprofessional consultations, which are practitioner to practitioner consultation services, and e-visits. And e-visits are actually very similar to the virtual check-in, except for they transpire online through something like a patient portal. We also, in 2019, began paying for certain remote monitoring services. Next slide, please. So now I'm going to cover some of the changes to Medicare telehealth in response to the COVID-19 public health emergency. So in order to expand access to telehealth in response to COVID, we used a combination of statutory waivers, the authority for which was given to us by Congress, and then our own existing regulatory authority. So using waivers, we removed the restrictions in the statute surrounding where the beneficiary must be located, so that beneficiaries in both rural and urban areas can receive telehealth services, and also that the beneficiary can remain in their home rather than having to travel to a medical facility and risk exposure to COVID. We also waived the list of practitioners enumerated in the statute, and we waived our regulatory requirement that the technology used to furnish telehealth services must be two-way audio video for a subset of counseling and educational services. We also began paying separately for audio-only evaluation and management visits. So as the waiver authority used to remove these restrictions is tied directly to the duration of the PHE, these flexibilities will in fact terminate when the PHE concludes. And as these are statutory restrictions, again, to make any of these flexibilities permanent would require an act of Congress. So as a companion to the waivers, we also undertook emergency rulemaking to remove any of the sort of remaining regulatory restrictions. There have been, I believe, a total of 4 interim final rules put forth by the agency. The 2 rules that dealt primarily with telehealth were the first 2, and those were published in late March and early May. These are temporary policies and they will expire at the end of the PHE. I think most significantly is that we expanded the range of services that can be furnished as telehealth by adding over 140 new services to the Medicare telehealth list. And these really were a range of services from emergency department visits to certain physical and occupational therapy services. Next slide. So I'm now going to turn to the calendar year 2021 physician fee schedule final rule. This rule describes the policies that we want to continue after the PHE ends, either as permanent policies or as temporary policies. So first, we added a number of services to the Medicare telehealth list permanently. These were services that we added provisionally during the PHE, but that we feel should be telehealth services from the time that the PHE concludes going forward. So these include lower level established patient home and or domiciliary visits, assessment and care planning for patients with cognitive impairment, group psychotherapy, and a couple of add-on codes associated with some previously finalized policies in the office outpatient E&M visit space. Next slide, please. We also added a range of services to the telehealth list temporarily. So this is an acknowledgement that right now clinicians are focused on treating patients. They're not focused on putting together requests to add services to the telehealth list, and that their experiences with a broader range of telehealth services might be able to inform requests submitted for consideration for permanent addition to the Medicare telehealth list through our standard rulemaking process. These services will remain on the list through the calendar year in which the public health emergency ends. And this really, we hope, will give the community time to consider whether these services should be available permanently outside of the PHE. Next slide, please. So as you can see on this slide, these are the services that we are adding temporarily to the Medicare telehealth list. So that includes lower level ED department visits, higher level established patient home and or domiciliary visits, certain psychological testing services, and nursing facility discharge day management. Next slide, please. So this slide shows services that we considered and that are available right now during the public health emergency as telehealth, that we decided not to continue outside of the PHE on either a permanent or a temporary basis. But I would note that that's not a sort of a final statement about CMS's position regarding these services as telehealth. We're very much interested in information on these services as well, and we'll consider any requests to add them to the telehealth list as part of our future rulemaking. So next slide, please. So for our communication technology-based services, in our final rule, we actually expanded the range of practitioners who can provide these services. Initially, they were just billable by practitioners who can independently bill for evaluation and management visits. But we expanded the range of practitioners to include licensed clinical social workers, clinical psychologists, physical and occupational therapists, and speech language pathologists. We also established payment for a longer virtual check-in that can be used to determine whether, again, an in-person visit is needed, and can be furnished using any kind of synchronous communication technology, including audio only. And we also revised frequency limitations for subsequent nursing facility visits. Next slide, please. So this slide describes our final policy for virtual direct supervision. So during the PHE, we adopted a policy where the direct supervision could be furnished using virtual presence of the supervising physician via audio, video, real-time communications technology. We are going to continue this policy through December 31st, 2021, or the end of the year in which the PHE ends. But we're interested in more information from the public as to whether we should consider adopting this policy on a permanent basis, and how to address any potential risks this policy might introduce to beneficiaries. Next slide, please. So real quick, these next few slides are going to describe changes in payment for remote monitoring. So in the rule, we clarified several of our payment policies related to RPM. We're finalizing a permanent policy to allow auxiliary personnel to furnish certain remote monitoring services under a physician's supervision, and clarifying that auxiliary personnel can include contracted employees. Next slide, please. We clarified as well that the medical device supplied to the patient as part of the RPM service must be a medical device as defined by the Food and Drug Administration, and that the device must be reliable and valid, and that the data must be electronically, i.e. automatically collected and transmitted, rather than self-reported by the beneficiary. Next slide, please. And finally, we clarified that RPM can be furnished for beneficiaries with both acute and chronic conditions. So with that, I believe my presentation is concluded, and I will turn things over to Dr. Graywall. Thank you so much.
Thank you, Emily. All right, so I'm going to share some lessons learned from our 3-year project at UF Health Jacksonville, where we implemented a telemedicine program specifically for HIV. Next slide, please. Just want to say a quick thank you to the folks who have helped us, not only my team from UF Health, which was made up of folks from family medicine, as well as our UF Cares department, who primarily serves our HIV patients, but also Health HIV, who also served on our project with capacity building, and then the CDC, who funded our project, and also our community organizations who served as partners on this project. Next slide. So just really briefly, we had a 3-year project involving the CDC, UF Health Jacksonville, and Health HIV. The first year was all dedicated towards planning, which at the time seemed like a long time, but as we were doing it, man, it went by fast. So I feel for you guys who have just, had to pick up telemedicine on the fly, because we had a full year to do this and it was still difficult. And we're going to talk in detail about what we did with planning specifically, but years 2 and 3 were all about the implementation of this project, collecting data on who used telemedicine, and then also conducting some focus groups. Next slide. So our project goals were to tailor our existing telemedicine program that UF Health Jacksonville had, specifically for patients with HIV. We are in an urban setting here in Jacksonville, Florida. Our goal was over the 2 years to have at least 200 unique patients utilize telemedicine for their medical care specifically, but also for some of the ancillary services that we provide. And some of the other outcomes we looked at were just viral load stability, patient and provider attitudes toward telemedicine, and we are currently doing a cost analysis as well. Next slide. So as we talk about infrastructure, and that was one of the things brought up earlier today, it was difficult trying to figure out, what do we do? So for us at UF Health, we already had some existing infrastructure, which was helpful. Our electronic medical record, Epic, actually does integrate with a platform. Now it's Zoom. It was initially when we started the project called VidYO, but we use Zoom now as part of our telemedicine platform. We also have an online patient portal, and so that made it easy on that end of things, but there was a lot of hardware that had to be bought for this project, and so we had to not only make sure that all of the offices had it, but that our community organizations had hardware, so and that patients knew how to get to the platforms that we were using. One of our big issues still, and I'd be curious to see if others are having the same issue, is translation services. So we do have a decent amount of patients who speak languages other than English. And so while we can do telemedicine with our English speaking patients, it's very difficult to have a language line integrated into that as well. And so that's something that we are still struggling with. Next slide. as we created our standard operating procedures, this was extremely important. They were very flexible, and these are living documents. So we are continuing to refine them, even though our project is officially now over. We are still working to update these. So this was very helpful for us to kind of identify and troubleshoot ahead of time, as we were able to kind of go out step by step as to how a patient would make an appointment, how would they get scheduled, how would we on the provider end be able to see these patients. And then what we did was to create quick reference guides for the folks on the front line. So the folks at the front desk who could use these to remind themselves and patients who are checking in about eligibility criteria for the project, how to do basic scheduling and check-in workflow, and where the tech support was. So these were important things that I think, if you're establishing a telemedicine program, you need to have some operating guidelines and have them readily available. Next slide. So we did a lot of training. We trained not only our staff at our HIV location, but also our staff at our family medicine clinics, and then also the staff at the community-based organizations who were also recruiting patients. So the training had multiple layers, and I think that's important as you're trying to ramp up a program to have lots of different ways to get the education across. So there was an independent study part of it, there was actual patient simulation, and then there was following an actual patient encounter by telemedicine, there was a follow-up done with the telemedicine educator where they debriefed. And I think that's important to get enough feedback so that providers feel comfortable doing this, that the staff feels comfortable doing this, because if there's not enough buy-in on our side of it, the provider side of it, it's not going to work well. Next slide. Patient engagement was another huge piece. And so we developed a lot of marketing materials. These are just some examples of some of the flat marketing that we had. We did some social media stuff on Facebook. We had billboards, we had bus stop ads. We had videos playing in the waiting room, radio ads. We had a lot of print materials for patients in exam rooms, big posters and things, as well as take-home materials as well. That we made sure that the take-home materials, we didn't specifically mention HIV because that was something that was important to us, was that we didn't necessarily want to disclose patients' diagnoses by mistake about talking about this project. Next slide. And again, patient education. So in order for patients to utilize a telemedicine visit with us, they needed to have access to our patient portal, which is called MyChart. And so we worked with Health HIV to develop some patient education materials. There's a set of videos that we share with patients. There's also some handouts that we give to them so that we make it as easy as possible, so that if they forget, how did I get to that video again? How do I get to my visit? They have something to fall back on. And of course, we have tech support as well, which is important. And one of the big pieces, and I'll talk later about this as well, is we found that, telemedicine is difficult enough to implement, but adding one more thing for all of our staff, I think, is difficult. So what really helped our project to take off was the hiring of a dedicated telemedicine navigator. This was a person in the clinics who was helping specifically just for telemedicine. That was her entire job, was basically recruiting patients, educating them about telemedicine, helping them sign up for the patient portal, and helping them, providing some tech support when they were able to get on the visits. So that, I think, if you are an existing program and trying to add telemedicine to it, I would say, try to see if you can get somebody on board who's just, focused on telemedicine, because I think that's going to help your efforts tremendously. Next slide. So our project happened in Jacksonville, Florida, which prior to the pandemic, we definitely had some issues with payer considerations. So there are no parity laws in Florida, which means that commercial insurances can do whatever they want. They don't have to pay for telemedicine if they don't want to. And we've heard about CMS, Ryan White as well, which is of course our #1 payer for this project. In the beginning, there really wasn't much out there to help us get reimbursed, and then COVID-19 hit. So at that point, everybody's kind of said yes, but even still, locally, we worked with our Ryan White folks. So even prior to the pandemic, in part because of policy clarification 16, there was a way for us to get paid, which was great. So, and we hope that these payments will continue post-pandemic as well, because we find that it's been very beneficial. Next slide. So now we're going to talk a little bit about our challenges and some of our solutions. Next slide. All right, so one of our biggest challenges was just trying to coordinate between everybody. So how our project worked, basically we needed to connect patients to UF Cares, which is our HIV center. And so those patients could get to UF Cares through one of many ways. If they had their own technology, great, they could connect remotely from wherever they were. But if they didn't have their own technology, then we made lots of different options available to them. So they could see one of the family medicine clinics. There's over 30 in Jacksonville. They could walk in there and the staff was already trained to let them have a virtual visit. They could just use one of the iPads dedicated for this project and go in the back or a quiet space and have their visit. They also could walk into one of our community organizations that partnered with us. So this was the Nassau County Health Department, Jasmine, NFAN, and River Region Health Services. So there are lots of places that they could also go if they were already connected to those services. The problem was trying to coordinate all of these places. So we had meetings, and more meetings. So I think that's the takeaway, is that the more players that you get involved, while that is helpful because patients have lots of choices and they can get access to technology, you have to keep everybody informed of all the changes all the time, and that can be difficult. So communication is super important. Next slide, please. All right, so another area was keeping providers and staff trained and engaged. This was a lot of change really quickly. So when we started the project, a few of the family medicine department providers were trained. None of the UF Cares providers were trained in telemedicine. So asking them to, hey, we're going to train you on this project and we're going to start implementing it fairly quickly. And there's some extra burden that we have to put on you with documentation. It was really easy to see how people could get frustrated with that. So how we combat that is by increasing training. So offering training in multiple different ways, as we talked about earlier, I think, so we could hit it from lots of different angles. Again, I'll mention that virtual visit navigator. That was huge because our staff, like I said, everybody's already overworked, and adding one more thing is just so difficult. So we were able to have this person really step up and fill in that role, and she just really took over this project. It was fantastic. And being flexible, I think, in the clinic workflow. So how can we make telemedicine work for us effectively? And you know, we found there were times that, all right, maybe we try to clump some telemedicine visits at certain times throughout the morning or certain times in the afternoon that tended to work better. And it was trial and error. So I think being flexible was important. Next slide. Next slide, please. For just with time, we'll keep moving. We talked about the education for empowered patients already, but and then so COVID-19 hit, yay, which actually was it was kind of funny for us because when it happened, everybody else, many of the other departments started panicking. The folks that have been involved on our project said, we're ready, we're here, and we've got it ready to go. So actually for UF Cares, it was a very smooth transition. The increase that we saw, though, was not so much in the medical visits, but actually more on the ancillary services. So we saw a lot more of our psychiatry visits, our nutrition visits, case management, pharmacy, research, all of those started really going up. And of course, the physician visits. So we had patients who were reluctant before the pandemic to utilize telemedicine. And now because of the pandemic, they decided, yeah, let me give it a try. And many of them have been very happy and have continued with it, even when the numbers kind of dip back down again. Next slide. All right, so now we'll quickly talk about some lessons learned. Next slide. So yeah, technology. So this is a good thing and a bad thing in many ways. From the patient's perspective, I think, as many of you have mentioned, the lack of access for patients. So we tried to make it as accessible as possible. Again, if patients didn't have their own technology, we gave them a whole host of other places that they could go to just so they could connect to their visit. And again, you know, with so many places, we were hoping that this would be something useful for them. But we did find that many many patients chose to just use their own technology, and if they couldn't do it, they wouldn't. Privacy, which was interesting. You would think that in some ways this would give you more privacy, but there were, of course, privacy concerns, especially when we switched to the Zoom platform. Patients were worried about, Zoom bombing and among other things, but also possibly having to disclose their status at home, where maybe, other folks at home were not aware of their diagnosis. So that was something that was kind of new for us. Educating patients on telehealth literacy. I think that's going to be a huge challenge going forward, and something that we need to do a lot more work on, as well as being flexible with technology changes. So every upgrade has a little new quirk, and so making sure that those changes get communicated to everybody. And then finally, quality of care. So, many of our patients felt that the visits were good, but some did feel that lack of connection through technology. So next slide, please. And then change. So I think that's the biggest thing, is if you're new to implementing telemedicine, or if you're in the midst of doing it now, be willing to change, be flexible, because the world is changing very rapidly. Telemedicine is changing very rapidly. Our patients and their expectations are changing rapidly. So, especially with the pandemic having come, we know all of us had to ramp up our services really quickly. Again, we were in a great place already with our project because we had it up and running. But I know for many of you, this was a difficult challenge. But don't be willing, I should say, to keep changing further as the situation progresses. Next slide. So a couple of things, these are just some very basic points that were taken away high level from some of our focus groups that patients reported as benefits from telemedicine. Some of the expected things, of course, we knew it would help with transportation and help with childcare and maybe be more convenient. Some of the things that we kind of weren't necessarily expecting was that they felt that stigma was minimized, as they were no longer having to walk into a place that was for HIV care. They were not seeing that, which is kind of cool. That some of them actually did mention that they had increased privacy because they were comfortable having their visits at home. Some of them felt that they actually had more patient and provider communication, which in some ways makes sense, since we're not necessarily doing as much of a physical exam. There is more time to communicate. Some of the other benefits that patients reported was they liked the patient portal because it gave them access to their medical records and their lab work that they had never looked at before. They also liked that it reduced the healthcare system navigation. So for our campus is very fun to navigate on. You park in one place, or you get on a bus from one place, and then you have to walk all over the other place to get to where you're going. So this was convenient for them, not having to do that. And then, of course, when the pandemic hit, having a reduced risk for COVID-19. So yeah, that was one of the things that they had mentioned as well. Next slide. All right, and then some of the barriers. Of course, we expected challenges with technology, and we tried lots of different ways to overcome this, and we're still working to continue with patient education and engaging our patients. But we've been pleasantly surprised with how many of our patients have done so well with technology, and it is hard having the adoption of technology and the capabilities. So patients are willing to do it, but maybe they don't have the tools. So trying to be flexible in how can we offer platforms for patients to get on from different places. And then some of the unanticipating kind of hindering factors were some patients actually felt that their visits were shorter than they were in the clinic. And I've sort of noticed that as well. I think some of my patients think that we're on a family meeting call, and it's like, no, we're not going to be here for 45 minutes. We still have our 30 minutes or 20 minutes. Also, some of the things were some decreased communication between patient and clinical support staff. So that was a little surprising to us. For example, communicating wait times. It's easy to remember when a patient's in a room to come back and check on them and say, hey, your doctor's running 10 minutes behind. But sometimes when they're on the screen and you have other things going on, you may forget to do that. So that was an education point for us. And then, again, as a result of getting some feedback about difficulty navigating the patient portal, we worked with Health HIV to create some videos and some more tools for patients to then have so that they could more easily navigate these systems. And I think that's all I have. So I'm going to turn it back over to Marissa. Thank you.
Thank you so much, Dr. Graywall. We are at time. So I do apologize. It was a lot of information and there might be some question and answer. We will track all of the Q&A. This meeting again is being recorded. We also can share PowerPoint slides following the meeting with the registrant. So I just want to assure you that you will have access to this information ongoing if you want to share internally with colleagues or revisit at some time. And then we can also make the connection to get some of your questions answered. I saw some specific questions probably for Emily Yoder and also for Dr. Graywall. But again, we are limited by time, so I do apologize, but want to just profusely thank Dr. Lecomte, Dr. Graywall, and Emily Yoder from CMS for participating in this panel, and share with you all how we'll start transitioning into the breakout rooms.